Erica is an occupational therapist at Aurora Sinai Medical Center in Milwaukee. She's certified in LSVT Big and is trained. She's a trained power provider. Erica is also an LSVT global faculty member, traveling throughout the U.S. and internationally, providing LSVT Big certification courses to occupational and physical therapists all around the country. Welcome, Erica.
Okay, good morning. Thanks, Gary. Okay, I'm just going to go ahead and share my PowerPoint here with everybody. Bring up our screen here. Okay, excellent. Well, good morning. I'm looking forward to sharing some good information with you this morning, and hopefully you have some good questions for me, and I can even expand further if you'd like to put those in the chat. I believe Jeremy is gathering those up for me for after I present. So I have quite a number of slides here. And I know we only have about 45 minutes together in total, and we're starting just a little after 11 here. So I'm going to do my best to get through them all. I know that you guys will have access to the slides also. So I may not read everything that's on each slide, but you can have that as a reference, and I'm definitely available for further questions after the presentation. So these are the objectives I have in the handout for you. You can go ahead and read those, but we'll just get right into the details of the information here. So what I first wanted to share with you was kind of talking about the prevalence, or how often do bladder, bowel, or even sexual symptoms happen in someone that has Parkinson's disease. So they did a questionnaire-based study looking at these bowel, bladder, and sexual health issues for individuals that had Parkinson's disease, as well as individuals that did not have a neurologic diagnosis. They looked at men and women, and approximately 6 years had gone by in the Parkinson's diagnosis for the individuals that they looked at, and all were taking some sort of dopaminergic replacement medication during this survey. And so what we're going to look at here, these are the women that they surveyed, and this chart shows the bladder significance of complaints in those women. And so the first column is the percentages of women with Parkinson's that have these problems or complain of these problems. And the second column is those individuals that do not have a neurologic diagnosis. And so what you can see is urinary urgency and nighttime frequency and weak stream are the most common complaints, with the others all as well being more than the average person that does not have Parkinson's. But these are definitely the three complaints that I hear about the most in the clinic. And then in women for bowel problems, as you can see, constipation and just getting stool to come out are also very high percentage-wise that people experience those. And then the sexual health complaints down on the bottom, a decrease in libido, significantly more of a problem in those women with Parkinson's and versus the control group. And then decrease in just frequency of sexual intercourse definitely was also up on the list of complaints. And then when we look at men, we actually see a similarity in regards to the bladder complaints. And so urinary urgency, nighttime frequency, so going a lot, as well as weak stream. And that's even more significant in men at 70%, because there tends to be some challenges for men with the prostate. And I'll show you a chart or a picture with a version of where the prostate is and why that definitely affects men, as women do not have that. And then looking at this one on the top is the bowel complaints. So constipation and difficulty getting stool out, definitely high on the list. Again, much more significant than in the control group. And then men have a lot higher percentage of complaints of sexual dysfunction. So libido, a decrease in frequency of sexual intercourse, orgasm, erection, and ejaculation, much higher than in the control group. So let's kind of talk about one of the contributing factors, and that's the pelvic floor. So the pelvic floor is really a sling of muscles in the pelvis, the base of our pelvis, that goes from the front to the back. So it attaches at the pubic bone and then goes all the way back to the tailbone and kind of attaches on all sides. And I like to think about the functions as the 4 S's. So the first one being sphincteric, meaning it really helps to control keeping urine, bowel movements, and gas in versus out. So we have voluntary control of that. It helps us support everything, kind of like a shelf per se, and holding up everything inside the bladder, the uterus in females, and the rectum and colon. It has a sexual function, so it helps with engorgement, so erection and orgasm, and also with stabilization. It works with our core and helps hold us up, helps us hold our big posture. This is just an image of the female pelvic floor. So the black line in the middle of the screen there, this is a side view of the person. And the pelvic floor is this black sling of muscle here in the middle of the screen. And you can see in the front on the left-hand side is the bladder, and it goes through the pelvic floor muscle to empty. And then the uterus in the female goes through the pelvic floor here, and that's the vagina. And then in the back, the rectum goes through the pelvic floor, and that's the anal opening right there. And the male, you don't always hear about the pelvic floor in males, but they have the same exact muscle. They just have a much more narrow space in the pelvis here for their pelvic floor. And what we see here, the black is the pelvic floor and the bladder here on the left. And then the urethra, or the tube that exits your bladder, goes through the pelvic floor. And then you can see right here in between the bladder and the pelvic floor is the prostate. And so that sometimes gets in the way of a male's urine stream, like I mentioned a little bit earlier. And then here in the back, the rectum, colon, down through, and this would be the anal opening here through the pelvic floor. And so let's kind of just talk about generally what should the bladder be doing. So the bladder really is a storage container, and it's supposed to be relaxed when it's filling up with urine, and we really aren't supposed to be so much aware of that happening. And at that time, our pelvic floor is just providing some tone for support of the bladder so that we don't leak during when it's filling. And then during this transition stage, what happens is we can recognize that sense, or kind of get that sense of like an urge, like we have to go to the bathroom. And then we can actually quiet that feeling by squeezing the sphincter and the pelvic floor muscles to just kind of quiet everything down and get the urge to kind of pass and calm down so we can make it to the restroom in time. And then lastly, we have the emptying function, where we can then socially choose to go into the bathroom. Our bladder muscle actually squeezes to let urine out, and the sphincter and the pelvic floor muscle can relax to allow that to happen. And so the average bladder really holds about 2 cups of urine at its maximal. So we say maybe 400 to 600 cc's or 13 to 20 ounces at a time. And again, those are maximal volumes at the max end. And urinating about 6 to 8 times per day is about average, or about once every 2 to 5 hours. And the first sensation to go is about when the bladder's half full. So 200 to 300 cc's or about 6 to 10 ounces. Completely emptying the bladder would be something we definitely want to avoid urinary tract infections, as well as not leaking urine is also what we want for normal bladder, and not getting up more than 1 time a night. When the bladder starts to act up, sometimes you'll notice, urinating more frequently than every 2 hours, small amounts of urine coming out where the urge might be really strong, but only a little bit comes out, waking up more than 1 time a night to go to the bathroom, difficulty getting to the bathroom in time. So that could be urgency, or even a little bit of leaking of urine that could happen, or leaking of urine with a cough, a sneeze, a laugh, lifting, or some sort of activity like exercise. Difficulty starting the urine stream once you get into the bathroom, so we don't want that to happen. Or maybe the stream kind of is hesitant. It starts and stops during urination. Or the bladder doesn't feel totally empty after going to the bathroom. And so those are the things we don't want to happen. Now, let me just talk a little more in depth about these things. So these are the different kinds of bladder incontinence that we might see: stress, urge, mixed, overflow, functional, and neurogenic bladder. So just to throw a little joke your way, Incontinence Hotline, please hold, just to kind of lighten up the topic a little. All right, so stress incontinence. The picture on the right just shows how this occurs. It's basically a leaking of urine when there's an increase in the pressure from above your bladder. So you have your bladder there, you get this increase in pressure. That's the arrows. And then what happens is the pelvic floor down here in the red line isn't strong enough to hold it back. And we get a little bit of leakage, like with a cough or a sneeze, or you lift something, or you exercise or laugh. And we can strengthen that muscle up to try to prevent that. There's also urgency or even urge incontinence. So urgency being really common in people that have Parkinson's. And it's a strong urge to go that you maybe can or can't stop, and it might cause this urine to leak out. It's often accompanied by high frequency, so more than 8 times in the bathroom in a 24-hour period. Or maybe people might complain of like, it feels like I have a small bladder. And triggers like running water or a key in the door or pulling into the garage might set that off. And sometimes it's also referred to as overactive bladder. And what's really happening is that your bladder is squeezing when you're not ready for it to. It's trying to empty when it's not time to empty. And you need to be able to kind of try to calm that, but it's not calming down. Then there's something called mixed incontinence. And this is really just a combination of both stress incontinence, which is the pressure on the bladder causing a leak, or in combination then with urge incontinence. You get the urge and then you have to rush to go to the bathroom, and a little bit comes out from the urgency. There's also something called overflow incontinence. And what this is when the bladder fills to a certain level, it causes a leaking or like an overflow. And sometimes there's a decrease in the ability to sense that the bladder is this full, and it may overflow. Sometimes this happens at night. So nighttime incidences of either leakage at night while sleeping may be due to overflow incontinence as well. And so at night, the bladder fills to a certain level, and maybe it doesn't awaken you, and it will leak while you're asleep. And so also some other things that could cause overflow incontinence would be if there's like a little bit of an obstruction in the tube that exits the bladder. So like an enlarged prostate, for one example, or sometimes too tight of a pelvic floor muscle. So if the muscle's too tight, it kind of kinks off the exit of the bladder. And some people might complain of the bladder maybe still feels a little full after going to the bathroom. And so some of those are the symptoms that might be felt. And we can work on those actually in therapy. Functional incontinence, there's a loss of urine due to inability to get to the bathroom timely. So managing your clothing, or some difficulty like with the fasteners or getting the pants down fast enough, or maybe even just rigidness from the Parkinson's, or a tremor or pain, or even individuals that have some sort of cognitive decline may have difficulty in kind of the sequence of using the restroom. And then neurogenic bladder is kind of a generic term for a bladder that just isn't functioning properly due to some sort of neurologic condition. And so overactive neurogenic bladder is the more common type in people with Parkinson's, but underactive types also do occur. So an overactive neurogenic bladder is kind of like the bladder is spasming. And the most common complaint with that is that you feel like you have to go all the time, and there's maybe only small amounts that come out of the bladder. And so there's this urge and then high frequency of using the bathroom. And then the underactive neurogenic bladder type is more of like a lazy bladder, if we want to call it. So they sometimes call that flaccid, where it's just kind of hanging out and it's doing its thing, but it's not getting in the ready to empty. So it might increase the risk of bladder infections because urine maybe doesn't all empty out. It becomes difficult to get that urine out, and may become, the bladder might become too full, or maybe a little bit weak. Okay, so maybe some overflow incontinence. And then you may have a problem starting a urine stream, maybe some hesitancy, or maybe unable to tell when the bladder is full. So changes of just sensations of what is the bladder actually feeling. So the common causes of bladder symptoms in people with Parkinson's. So I have some charts here that have a lot of information, but what I want to do is just share some of the symptoms. And when we look on the left-hand side of the chart, I have that labeled, when the brain has less dopamine. So due to Parkinson's disease, the brain may have less dopamine, and the bladder is not easily calmed down, or what we might say is inhibited during storage. So we want the bladder to be nice and calm when it's filling up, but it might cause this gotta go signal to be really aggressive because it's not calm during filling. And so what might happen is there might be a lot of urgency or incontinence or nighttime frequency or some of the other symptoms that I show on the right-hand side of the screen. Also, when the brain has less dopamine, the bladder gives a really strong gotta go signal when there might be only a little bit of urine in the bladder. So it might be going to the bathroom more often and cause some of those same symptoms of urinary urgency and incontinence. Also, when the brain has less dopamine, what else does the bladder do? So when we think about the sphincter and the muscle, there may actually be some slowness, just like the muscles in other parts of our body, our arms and our legs. The urinary sphincter or pelvic floor may be really slow, and it may not react fast enough to actually hold urine in. And then we rush to the bathroom, and then the bladder is trying to still contract pretty hard. So it may still cause some urinary incontinence because we can't get the muscle and the sphincter to close up fast enough. Additionally, when sitting on the toilet after trying to hold urine in to get to the bathroom, sometimes the muscle actually won't let go as easy. And so there's this slow release, and the bladder doesn't get a good signal to say, okay, I'm going to empty now. And so the bladder is trying to contract kind of against like a little bit of a closure of basically the exit to get the urine out. This can cause bladder infections or maybe even straining to go to the bathroom or retention of that urine. When the brain has less dopamine, we also get weak bladder contraction sometimes, or pelvic floor muscle weakness. It's just like any other muscle in the body, and it may cause, again, a lot of these kind of irritative bladder symptoms. The pelvic floor muscle weakness in particular will not support the bladder enough to calm urgency. So the challenge with the pelvic floor muscles, we want to really get it stronger and active, more active, so that it can calm those urges so you can make it to the bathroom in time. And then also when the brain has less dopamine, we may have a functional issue, right, with our other muscles, so like walking and balance and getting out of chairs in time to make it to the bathroom, or maybe having some tremor that causes some difficulty in managing in the restroom. So those are just some of the things that I wanted to share with you and kind of thinking about why are these things happening and what happens with the bladder when we do not have enough dopamine. So some of the things we might work on in therapy would be trying to eliminate first some dietary irritants, thinking about caffeine as an irritant, carbonation, alcohol, artificial sweeteners. Those are some of the top of the list. Also, spicy foods and acidic foods like lime, lemon, tomato, grapefruit. Some of those things can really set off bladder irritability as well. Drinking more water. So you want to really maintain a light urine color. And the typical recommendation right now is to drink about half your body weight in ounces every day. And for some, that might seem like a lot. And potentially you might be one that has actually limited water intake because of the rushing to and from the bathroom. And so you don't want to go from hardly drinking anything to drinking this much all in one day. You want to slowly start to increase. And usually I tell people, you know what, even if we can get like a glass of water in at each meal, that could be a really good start to kind of upping the water intake. Constipation is the third point here. So constipation is actually a causal factor of bladder urgency. And so getting rid of constipation is really important. Sometimes the bladder just starts to behave better just by eliminating constipation. Sometimes we may try scheduling going to the bathroom or using distraction techniques, which I like to call mind over bladder. And so we would learn how to use the muscle and or distraction to try to extend the time between going to the bathroom. Limiting fluid intake in the evening can be helpful, as well as potentially elevating the lower extremities a couple hours before sleep and what we call like pumping the ankles. So flexing and pointing the ankles to kind of get some of the fluids that may have settled in the lower body throughout the day to kind of reintegrate into the bloodstream and then fill your bladder before you go to bed so that you can empty that out. Also, because sleep can be a major problem in Parkinson's, we always want to work on good night's sleep and sleep hygiene, because sometimes we don't know, is this really a sleep problem or is it a bladder problem that's waking you? Sometimes we recommend using a urinal or bedside commode, especially if you have some off times in the evening or in the nighttime that makes it difficult to walk to the bathroom. And also reducing weight can help. So increased abdominal weight, even decreasing that by 5 to 10%, they show in the research, can actually really relieve the bladder of pressure. So if that's something that could help, that would also be a suggestion that we might look at. Now, this is a diary of something that I might have someone do, say, the first time we come in. I have a variety of different diaries that I use. This is just an example of one where we look at like a 24-hour period. So midnight to the following midnight. may have you actually measure the amount that comes out. So in that second column, it says amount voided. So I might have you just say small, medium, or large, or even more helpful, actually measure in one of those hats that you put into the toilet. We get an amount that comes out, and I can compare that to what we talked about earlier in the presentation, what's normal to come out of the bladder. And then, of course, would want to know when the leaking is happening. So I can kind of compare how much was in the bladder, when is the leaking happening, maybe there was an activity during the leaking. So that's that next column over. And how much urge was present. So I really like to look at, okay, did we have a small amount in the bladder and the urge was strong? Or did we have a really large amount in the bladder and the urge was strong? So we want to look for some of those cues that the body might be giving. And then I may have you track how much you drink. So that can help kind of bring the picture together so that I can give you individualized kind of guidance as to how to help your bladder. Another thing I just wanted to mention is sometimes a physician like a urologist, so someone other than your neurologist, okay, like a urine bladder doctor, urology, or even maybe your general doctor may prescribe a medication for bladder management. And I just want you to know that they are not highly recommended for people with Parkinson's, only because we do get a lot of unwanted side effects, especially some cognitive or changes or confusion, dry mouth, and constipation, which constipation is already a highly rated complaint in people with Parkinson's. So it's not that these medications don't work. They are used sometimes, but there is some caution in when they are prescribed. And you want to definitely touch base with your neurologist or movement disorder specialist about how they might be affecting you if you decide to take one of these medications. All right, let's talk about the bowels. So the normal events of bowel function is in the morning when we get up for the day and we eat or drink something, along with just gravity of being up and about, causes movement of stool within our system. And the sphincter and the pelvic floor muscles try to provide some support, and we're pretty much unaware of those maybe initial movings inside of us. Then there becomes an awareness where we feel an urge, and we can actually voluntarily tighten the pelvic floor or the sphincter and kind of slow things down until the condition's appropriate to use the bathroom. Then we have the third stage of evacuation where we sit on the toilet, our muscles and the exit relaxes, and actually the rectum contracts to kind of push the stool out. And then we have this completion where your rectum goes back to, I'm going to store more stool, while your muscles and everything kind of just relax and close up for the next filling of the rectum. So normal bowel function is a wide range, 3 times a week to 3 times a day. So ideally, 1 time a day is kind of the average. We like to shoot for that, especially if there are bladder problems. We want to try to have a bowel movement every day. We really don't want to have any leaking of stool. That's not normal. We can work on that. The consistency of stool should be soft and formed and easy to pass without straining or without pain. And ideally, we really need to have some sort of sensation that there is stool there or that we get an urge. And bowel dysfunction would be less than 3 times a week or greater than 3 times a day. And hard or watery consistency, a straining like breath holding, or incontinence with some sort of increase in pressure on the colon rectum, like we talked about with bladder, kind of similar, or leakage or kind of seepage after you go to the bathroom. So you're done going to the bathroom and now there's something that's coming out afterward, getting onto the skin or onto the underwear. So some of the common causes in Parkinson's, so when the brain has less dopamine, the stomach actually is a little slower to empty. So that can kind of cause maybe less intake, right? We have maybe less appetite or early fullness, maybe some bloating. So that can affect how much is actually in the colon to be processed. Then we have this colon or intestinal movement that is actually really slow and sluggish because of the lack of dopamine. And so that can cause all kinds of issues, especially constipation and hard stools. Also, when the brain has less dopamine, there is some difficulty in pushing stool out. So what happens is in the bowel system, our abdomen actually has to help with a little bit of a strain, but there's a just right way to strain, okay? Because breath holding strain actually closes the exit. But there's an effective way that I use during therapy and training to train those muscles to effectively help push stool out. Also, the challenge with less dopamine, the second one there, is that the rectum actually doesn't contract strong enough to let the stool out sometimes. So we have this more inactive or kind of lazy rectum, and the rectum isn't adequately pushing the stool out. So sometimes laxatives are needed, but we can also do other kinds of training in therapy to help with these things. Also, when the brain has less dopamine, we might sometimes see that the exit actually is too tight and it's kind of closing. And so there might be a little bit of an obstruction of your own muscle. So just like we get kind of rigidity and stiffness in other muscles in the body with Parkinson's, we might get the same thing at the exit for having a bowel movement. There may also be weakness of the pelvic floor. And so when there's an urgency to have a bowel movement or maybe some incontinence, that could be a causal factor, and we can work on that. And then also another thing that can happen is swallowing difficulties, which may lead to dehydration or poor nutrition. And that affects the movement of everything in the bowel system when we're not taking in adequate nutrition. And then additionally, just like with the bladder, if there's a lot of immobility or difficulty with movement or getting the clothes managed, sometimes you get in the bathroom and the urge has passed already. So we lose the urge, and the urge is so necessary to get the rectum to empty out. All right. What can we do about the bowel? So kind of some things that we might start with on the basics is that maybe starting a daily bowel routine, really important, about 10 to 15 minutes sitting on the toilet a day. Sometimes this is best done in the morning, either after waking or after eating. Maybe even after drinking a warm drink. Some people find coffee very helpful. Using a good toileting posture. So a footstool under the feet so that your knees are up, and then kind of bringing your elbows down to your thighs. And so that leaning over, kind of squatty potty is the name of the tool that I sometimes recommend people purchase for that. And or just a basic stool under the feet. Deep breathing and relaxation. So getting the air down into the belly with a diaphragmatic breathing, we call it. So breathing into the belly instead of into the shoulders. So if you breathe more at the shoulders versus down into the belly, we say sometimes big belly, hard belly to have a bowel movement. And so getting air down into the belly helps the colon move. I also use something called 4-7-8 breathing. And what that is you inhale for the count of 4. You hold your breath for the count of 7. Now, during that breath holding, you might feel kind of some tightening in the abdomen around the colon, and it kind of gives it a little bit of compression. And then for the 8th breath, you let the breath out with a big exhale, either with pursed lips, so tight lips, like you're blowing out candles or blowing up a balloon, or you can kind of let it out a little faster. You can kind of play around with that. But the letting go of the breath helps relax the body. But also if you use resistance like pursed lips, you can get a little resistance for a little bit of the abdominal push to help with the bowel movement. So I really like that 4-7-8 breathing technique. Also, general exercise. So as Gary mentioned in my bio, I'm all about exercise and Parkinson's. So exercise absolutely helps the bowels keep moving. Another thing is consuming about 25 to 35 grams of fiber each day. Now, the important part of this actually is the adequate water. So if you take in 25 to 35 grams of fiber every day, but you don't drink any water, it actually will make the bowel program worse. So I definitely don't want that to happen. So you have to have water. When you mix fiber with only a small amount of water, like for example, psyllium or like benefiber, it hardens up or kind of thickens up really fast. And if you don't have a lot of water to kind of rush that through because you're trying to get bulk in the stool, then it kind of gets stuck and you're in the same situation. Or eating facilitatory foods like roughage or prunes or things that kind of get things rolling. Then there's also something called the I Love You abdominal massage. And I believe, yes, my picture is on the next one. So let me show you what that's like. So when you're looking at the body, the I is this ascending colon. So you rub in circles up the I for the I. And then the L, you start down here again. L goes all the way up through the transverse colon. So L. And then the U goes all the way around and then into the descending colon. So you can rub in circles with some pressure on the belly and then the I, and then the L pattern, and then the U pattern. And they have shown that abdominal massage every day can really be of benefit. Unless doing it every day, though, it doesn't show like a long-lasting benefit. So you do have to kind of keep up with it to keep the bowels rolling. Okay, and this is another bowel health kind of power pudding little tip here with a cup of applesauce, a cup of unprocessed oats or wheat bran, and then a half a cup of prune juice. You mix that together and it kind of forms like almost like a pudding. And what you do is you eat about 2 tablespoons with that. And then along with that, you drink the about 8-ounce glass of water. And so you don't have to mix the water and the power pudding together. You drink them, eat and drink them separately. And what happens is it just helps to provide a little more bulk to the stool to get movement. You want to start off with this very slowly because like I mentioned on the last slide, if you have too much fiber, not enough water, that can really cause more problems. So you really want to potentially even work with somebody that can help you kind of monitor this and work through this. And that's one of my roles in the clinic as a pelvic rehab specialist. What we're shooting for with the bowels, and this is kind of how we monitor, like, are we doing a good job with water? Are we doing a good job with stool, with fiber for the stool? When we look at this chart, type 4 is really about where we want to be. And so we want it to be smooth, sausage-like, snake-like, and formed. So that's how one of the ways we kind of use to figure out if we're on the right track. Okay, and then we'll briefly talk about sexual dysfunction, and then we will move on to some questions. So these are just charts for your reference of what the normal sexual response cycle is. So you have the desire, excitement, plateau, orgasm, and resolution, and that happens in both the male and the female. And so in general, when we think about aging, men and women both have reductions in testosterone, for men, testosterone, and estrogen for women that occurs over our years of life. Arousal becomes less intense for both. We get some atrophy, we call it. So that's this word right in the middle. So maybe some thinning of tissues and some weakness of tissues. It may take longer to have an erection or to get an erection. In women, there might be less lubrication or thinning of the vaginal walls or pain with being with your partner. And so the reason that this happens, when the brain has less dopamine, like to look at this side here on the left, there's less libido and less interest. So dopamine actually drives our libido and interest. Our reward system is kind of dampened down. And so it can cause a lot of challenges. And, you know, one of the things here, reduced lubrication for women. And that if you don't have the interest or the desire, that can definitely affect a lot of things down the chain of sexual function. Less ability to experience sexual arousal. So dopamine affects that ability, and we can't get as much arousal for sexual activity. Additionally, when the brain has less dopamine, the body isn't functioning the way we want it to. And so when you can't move the way you want to, it may be harder to position, and there may be less arousal. Or there may be a fatigue that might be involved. Additionally, pain may be a problem, and dopamine replacement medication in some people has caused some hypersexuality symptoms, but that's not in everyone. But I just wanted you to be aware of that. And then also like mood, if you're not in the mood or less aroused, like any anxiety or lack of sleep, all those things that can affect like arousal or interest is a problem. And dopamine affects all those things. And then we may have pelvic floor weakness, which affects ability to obtain an erection or an orgasm. So just in brief, some of the behavioral strategies that I sometimes suggest to people is that, try to find intimacy in things other than maybe sexual intercourse. Maybe you find that in day-to-day life, showering with a partner, using nonverbal cues, using music to set the mood, or trying to have the encounter earlier in the day when either the medications are on or you have more energy. Pillows for positioning. Those are some of the things that we can talk about. Stretching, wearing loose-fitting clothing. The partner with Parkinson's maybe be in the least strenuous or least restrictive position, using different lubricants. So I have a lot of suggestions for those things if in therapy that we talk about. And then sexual dysfunction can also lead to depression, sadness. Intimacy and exercise can be mood enhancers. So that can be a really important part of people's lives. And so I'm definitely one of those individuals that when you come to see me, we can work through these things in addition to all those things we talked about earlier in my talk. There are other things you can do medically as well, like hormonal creams or hormonal things that physicians do prescribe. So the last part of my presentation, and this is in the slides for you, is that really exercise is so important for the pelvic floor because it contributes so much to the healthy functioning of the pelvic floor. And I apologize for the background noise. I'm not sure if somebody could mute their computer for me. Okay, so basically when thinking about when the brain has less dopamine and pelvic floor exercise, there's like a loss of automatic ability to use the pelvic floor. And so we need a lot more conscious attention to it. And so for bladder and bowel functioning and sexual health functioning, we have to learn how to pay more attention to the pelvic floor and learn how to use it in a more coordinated manner. And so the pelvic floor may move smaller or slower, and we can actually retrain that in the clinic. And if any of you have ever experienced freezing, this can happen in the pelvic floor. And so we can work on that and train that. So we work on effective contraction strength for control of the bowel and bladder, and that's for storage in the red here. And then effective softening and relaxation emptying. That's for empty. So we want to be able to not only contract, but also be able to relax. And so you may have heard of Kegels. So Kegels are what I train in the clinic and more commonly maybe called pelvic floor exercise. And so there's strength that we work on as well as endurance. And so I have listed for you some of the exercises and how I initially get started with those. So these are the power squeezes. You hold for 2 seconds, you rest for 6 seconds. And I usually have someone start with those 10 repetitions 3 times a day. The long hold, these are a little more submaximally because we're working on endurance, holding for 10, resting for 10, and do that 10 times 3 times a day. Okay, and I would train you to do this in the clinic. So this is just a picture of the male pelvic floor. You see that here in the black. And when it's relaxed, it's loose and these areas are open. When it's contracted, you can see its shadow here, and then the contraction lifts everything up. And then in the female, the same thing. When it's contracted, everything lifts and holds. So I have in here a little bit about what we would potentially do in one-on-one therapy, some questions to ask yourself as far as if you're having some of these troubles, would you potentially benefit from some therapy? And what some of this therapy might consist of is the things that we've talked about today. We talk about the symptoms, we review the diaries. If I had to do one, we would work maybe externally or internally on assessing what these muscles are actually doing. And we may use something called biofeedback as one of the options. And so biofeedback uses what we call an EMG. We're gathering some body information through some signaling, and I'm going to show you what that is, okay? It has shown in the literature that people that have not been trained by a medical professional, 50% of them typically do pelvic floor exercise incorrectly. And so it can be really important to optimize your gains with these exercises if you have somebody that can help you get trained in that. And biofeedback also has shown to help with long-term and even short-term effectiveness in managing incontinence, managing bowel and sexual function. And so these are just an example of some of the sensors that we can use. This one is for the vaginal area, and this one is for the anorectal area. So women, we can use either one, or with men, we just use the one on the left. And this is just an example of what you might see on the screen as far as squeezing, relaxing, and then opening for emptying. And so that's how I can kind of tell if the muscle is coordinated and working correctly. And then we can work on some squeezes and relaxes, as well as some longer squeezes and relaxes. And just to note real quickly on this one, you see on the bottom in the pink, that's the stomach muscles kind of getting involved. And so I work on training isolation of the pelvic floor so that you're only using the correct muscle. Okay, we made it through all of these slides. I'm going to stop sharing my screen here, see if I can get back to you guys here. There we go. Thank you so much. Is there questions you have for me, Jerry?
I have a few questions for you, Erica. First of all, thank you so much. As I told the last speaker, I'm sure if you listen, you can hear people applauding and thanking you for doing this. We do appreciate this is a very difficult topic, so we've had some really good questions that we will ask you. One of the first questions that came up is, can loose bladder or loss of elasticity of the bladder, is that caused by Parkinson's disease? Is there anything they can do to maybe improve that loss of elasticity?
Yeah, so sometimes if the bladder has been overfilled potentially too many times, we can get kind of that overstretching of the bladder. And so we really want the bladder to be a little more compressed so that it will empty adequately. And so, yes, there are some ways that we can try with some techniques of timed voiding to try to get the bladder to actually respond to lower volumes for emptying. So yes, there are some techniques that we can do.
Perfect.
Here's somebody's phone ringing.
I don't know where that is. Sorry about that. The other one was, can I have a...
Morning, it's Ruth. You know that already. Can you let Jeremy Justin know that I am sitting in as an exhibitor?
Carolyn, we can hear your
from him.
Meeting.
Having problems.
The joys of virtual programming, everybody. You're just learning something new here. So one of the other things that came up, sorry about that, Erica.
It's okay, no problem.
Strong stream. So some people said, you know, I notice I have a really strong stream, but barely anything's coming out. Is that common with Parkinson's disease, or is there something else going on?
Yes, very good question. So what can happen with that is, remember how I was saying with less dopamine, the bladder can actually get really aggressive, like it wants to really push urine out. Okay, so your bladder, when there's less dopamine, the brain is not telling the bladder to be calmer. And so we can get these really aggressive streams. In addition to that, though, sometimes that's actually a little bit of a tightening or a obstruction, let's say, around the urethra, kind of preventing urine from getting by easily. And so the bladder really has to push super hard to get through that space. And that can be from a prostate or a tight pelvic floor or a tight sphincter. And so we work on that in therapy to try to figure out actually what's happening with that. So, and I have people measure volume. So when you say not a lot comes out, I really like to actually know how much volume that is. And then we can try to figure out why it's coming out so aggressively, if there's something we can fix with the muscle.
Excellent. So one of the other questions that came up was, is it common with Parkinson's disease that a couple days I'm constipated, next couple days, you know, then I have really, really loose stool and I'm going all the time. And then it kind of fluctuates between constipation, loose stool. Is that common, or is there anything I can do for that?
Yeah, so that actually is fairly common. The challenge with that, and I don't know if that person that asked that question is taking Miralax or doing some sort of supplementary.
Hello, this is Ruth. Can you hear me?
Oh, goodness. Okay, let's see.
Sorry, we keep getting Ruth's phone call. Sorry.
Okay, let's see if this, okay. Okay. Yeah, so the fluctuating between constipation and loose stools can be a real challenge. And so in therapy, we do a lot of work with trying to balance out how much, say, laxative versus fiber, and really getting that down pat so that there isn't a lot of that fluctuation. And so regularity can really be established with work with a pelvic rehab specialist, because we really get in depth about what's going in and what's coming out.
Excellent. So the last question I have, and I know a couple more have come in, and those that we don't get to today, we will try and cover in a magazine issue in the future, or there may be other ways we will get to some of those questions. But one was a little more specific, but somebody has an abdominal hernia. So it makes it very hard to squeeze and push out. Are there other techniques you might have for somebody who has abdominal issues, a hernia, or other problems to really properly void the bowel or bladder?
Yeah, that's a really good question. So the abdomen, as I mentioned during the presentation, plays a huge role in getting stool to come out. And so what really in that, because that's such a specific situation, what can really be helpful is if I could assess that in the clinic to figure out how to better actually strengthen the abdominal muscles in the right way to help with that strain or push the right way. Because if you're breath holding and really pushing hard, typically that's actually closing the exit rather than opening it. So it does take a little bit of coordination between the abdomen and the exit. And so we also don't want to worsen an abdominal hernia by breath holding and pushing, because that air has to go somewhere. And so that is a really important question. If that person wants to chat with me more about that, I'd be very happy to help them with that.
Excellent. Well, thank you, Erica, so much. I think I've been reading the comments. A lot of people have really thanked you. They said you covered this topic, a very uncomfortable topic, in a very, very comfortable way. So they appreciate that. We always appreciate your time. So thank you so much.